We are live. You are on the Secrets of Success podcast with Dr. Shane Needham, and I have Karl Lambert here. He's an ARNP. We'll get to that in a minute. We're going to be talking about some really cool and I guess very topics that are of interest to people right now. It's certainly of interest to me, and I know I'm going to learn something from Karl. We're going to be talking about COVID-19, herd immunity. I know it's a very important topic, and it's a very, what would I say, controversial topic. We're going to be talking about masks and what Karl thinks of masks, and should we wear masks? What's the science behind wearing masks? And of course, we're going to talk about his practice and his business and his clinic of direct primary care, which is, I absolutely think, that one of the future changing modes of healthcare. So again, you're with Dr. Shane Needham, Secrets of Success podcast, where our theme is never be outworked. We're going to get into that mindset in just a minute, where we talk with Karl, and he has that never be outworked entrepreneurial mindset. Follow me on Facebook, on Instagram, on LinkedIn. Visit my website at drsneedham.com. I also have a YouTube channel. You can follow my YouTube channel. You can see all my previous podcasts, and we'll upload this one to there as well on YouTube, on Spotify, iTunes, SoundCloud. You can call in today. We're streaming that number across the screen below, 877-995-2111. If you call in, we'll put you on an immediate hold. You may hear me and Karl in the background, but we will get to you. So why did I start this podcast? And I absolutely consider Karl a scientist. One of the reasons is I wanted to give scientists a voice to the global community. Typically, we, as doctors and as scientists, we publish in white papers, we go to conferences, and that's all good. But that really doesn't get the information out to the public like we need to necessarily. So we wanted to have a social media platform where we could absolutely deliver a voice from the scientists to the global community. And how important are we seeing that is now today with all of our quarantines and COVID-19 and testing and all that. So thanks again, Karl, for being on my show. I wanted to mention one last thing before I move on. Thank you to my listeners and my viewers. Over the last just a little over a month, I have had 100,000 engagements on social media. Thank you. Whatever we're doing, it is working, and I could not do it without you. Thank you for being a big part of that for me and with me, and just without your support, we couldn't make it happen. So thank you very much, and we look forward to growing those type of numbers to even 10 times that. So thank you very much. It's a very exciting time to be in this industry. So Karl, tell me your story. Introduce yourself. Tell me your story. Tell the viewers and the listeners about yourself, what you do, and you can start from whenever you want.
Wow. I could start way back in Philadelphia then, right?
Absolutely. Absolutely.
Okay. So I was born in Philadelphia, but had lived most of my life in the Pacific Northwest. Grew up in Oregon, loved, living there, loved living in the Pacific Northwest, Washington State. Absolutely fantastic place to live, just in terms of all the things there are to do. I graduated from Seattle Pacific University as a nurse and worked for 10 years at the Fred Hutch Cancer Research Center, which really,
Wow.
Yeah, there were many great facets about kind of working there, just in terms of understanding research and all the statistics that go into that. So that really kind of gave me a good, solid foundation. And then it was like, okay, it's time to go back to graduate school, and went to the University of Kentucky and became a nurse practitioner, and then jumped into that role back in, I want to say 1997. So it's been quite a while. And it was during that process, Shane, that I'm thinking, okay, there's something that's missing from this whole family primary care piece. I mean, it was just getting exhausting in terms of just seeing the numbers of folks that we have to see and then sending them out with a prescription. And to me, it was like, this is not it. So I think part of what I've discovered in my own personality is if I see a system that's not working, oh my goodness, my brain starts thinking about how to tweak it, how to change it. And I couldn't within the framework I was working. And that was exhausting. I was beating my head up against a brick wall, essentially. So left the system back in 2006 to start my own practice, and then really it's evolved to it is what it is today, which is more of an integrative, holistic perspective using the good scientific evidence that there is really on both sides. It's like there's ditches that we can all get into, in terms of mainstream medicine and even the naturopathic medicine. There are ditches, and so really the integrative functional medicine tries to kind of bring the best of those worlds together.
Yeah. Well, that's very interesting. So number one, I didn't know you were from Philadelphia, and I didn't know you worked at the Hutch. That's what we call it, the Fred Hutch Institute. We call it the Hutch, and I've certainly done my share of work with him, and my company has as well. That's all public information. We've presented some things on that. So what did you actually, because this is fascinating. This says a lot about you. I follow you on social media. I follow your statistics, and you're very interested in statistics about COVID-19 and so on and so forth. So what did you actually do at the Hutch?
Well, the first 8 years was direct patient care with folks from all over the world coming in for bone marrow transplants, because Fred Hutch was the place, or the Hutch is, you're right, we called it, was the place where nobody else wanted to take them, so the Hutch would take them and treat these folks. And so, you have 1 to 2 patients typically, and boy, I had some great experiences with patient care in terms of taking care of the Russian pilot that flew over Chernobyl, taking care of some really
My
incredibly,
goodness.
oh yeah, the stories I could write about the people that I met during that time frame, and just, that, and you learn a lot, of course, from meeting people from all over the world. It just really expands, your own little small microcosm of a world to suddenly, wow, there's a whole world out there, right? And then I transitioned from doing patient care, partly because 8 years of being in the trenches, and you see a lot of these folks die, and the death toll is really is taxing on you as a human. And so I transitioned to a research sub-investigator research role there, and just mostly just looking at numbers, doing a lot of the grunt work for the principal investigators, and it was mostly pharmacokinetic studies. So it really fascinated me, the whole world of pharmacology, pharmacokinetics, its impact and role at the cellular level. And I actually kind of became a little geek for those 2 years. But I learned a lot about statistics, learned a lot about kind of that whole world of research. There's both the good things about it, and then there's some dark sides to it.
Yeah. What would you say the dark side of research is?
There was 2 investigators, 2 PIs I was working with, and one, my goodness, he had a hard time getting published, and the other one was published a lot more, and sometimes he had me adjust some numbers to make sure he got published. And the other investigator was so highly ethical and detailed, and he just he would, it's like, nope, that's what the number is, we're going to stick with that.
Yeah.
And
For those of you that don't know what a PI is, a principal investigator, and I guess they're a lead researcher in a laboratory. That's probably the easiest way to describe it. And that's certainly some of the issues with our, I guess, current research system, is that there's actually a term they use in academia. I don't know if they still use it, but publish or perish. And sometimes, and sometimes if you don't get published, you can't get tenure at a university. So obviously you're not going to get as many grants from the NIH or CDC or whoever is giving out that grant. In general, you need to have publications. And I agree with that. But why don't you talk about, because I've seen you talk about this recently, and I think it's very pertinent to this topic we're on right now, confirmation bias. I think we're seeing a lot of that in some of the COVID-19 statistics. Why don't you talk about that?
Right. So, confirmation bias is one of those things that we as clinicians need to protect and guard ourselves against almost on a daily basis. It's, so you see the data, you realize that, okay, it's this data mining going on there. they're giving us this information, and do the statistics support it? Is there enough of a p-value that it's specific enough? There's just so much you really have to kind of dig into, and then you just can't take one study and say, okay, that's gold. No, you got to keep going, right? And so with confirmation bias, you can start going down one rabbit hole and you go, no, I'm not looking anywhere else. Use the example, mask work, right? That's the mantra we keep hearing.
Yes.
And yet I don't see the data to support it. I mean, even CDC and some of the studies it's put out there, random control trials, and at best, hand washing absolutely works, but they cannot come out and say masks do work. But it's easy to get a confirmation bias and start going down that trail of mask work. Yes, absolutely.
Why do you think? Why do you think that is? Why is it easy to get a confirmation bias? How does that work ideologically, maybe psychologically? What are your thoughts on all of that? I've wondered myself.
I wonder if part of it is, it could be a comfort. It's like, hey, I'm just going to stick with this belief system. So it really depends on, there's so many matrices that we can get our brain wrapped into, and we have to. I think one of the challenges in this day and age is, how do we come out of that, whatever that perspective or that matrix is that we have found ourselves in, to come out and go, okay, let's dialogue with someone else that's coming from another perspective. But I see what's happening even on, our professional online system. What was that called? LinkedIn.
Yeah. Yeah.
There is bashing that goes on instead of dialogue.
Yeah.
I expect the bashing to take place in the Facebook realm.
Right. I've started to see. Karl, I'm observing the same exact thing on LinkedIn. LinkedIn, for those of you are maybe just Facebook or Instagram followers, LinkedIn is, I don't know how old the social media platform is, but it was built solely for business, really, for business and science connections. You're not, in fact, if you post personal things on there, they'll actually say it's not appropriate content. So it's only supposed to be business and science. But now what we're starting to see, I've really only seen this during COVID-19. We're starting to see ideological posts, things that really weren't considered acceptable previously. Wouldn't you agree with that, Karl?
Yeah, I would agree with that. Just it seems like there is just so much, it's got to be pent up anger. It's hard to really kind of know what's going on behind it.
I can't explain it either, but we're starting to see it even on LinkedIn. So all across the industry and on the media. And certainly confirmation bias is something that we have to be aware of. And so you have to take all your data into consideration and then decide on making a choice for yourself and educating yourself. And that's the thing, is science is never done, right? I mean, there's always going to be more and more data delivered. I'm with you. I'm still looking at the data. I'm not convinced that masks are working. I don't see how they would, but that's a whole, probably another topic. And so that's interesting. And so tell me about how you deal with the mask situation in your clinic. And Karl is actually in the state of Washington, and I can't remember the mandates there. You can probably talk about those and how you deal with it to make your patients comfortable. He's got one on. Perfect visual right here.
There we go. How do you like that?
I like that. I like that. That is absolutely perfect. Absolutely perfect. Excellent.
And I had one patient say to me, "Oh, and I can still see your smile, and I can still see life." And I think one of the things, a comment that I heard, I think it was last week, they said, "Have you noticed how people don't make eye contact anymore? They've got the mask on," and it's like, "Well, I haven't noticed that. You go into stores and people just don't look at you."
It's true.
We're losing kind of all of our social etiquette and just being able to relate with one another.
You brought up your patient that they talked about a smile. I wonder if that's why it is, because if we look somebody in the eye, we can no longer get a response from them, because it's usually based upon a smile or a grin or a sadness face or a frown a scream, whatever it is, but we can't see that anymore. And that is very interesting. It'll be interesting to follow these potential psychological, mental, and emotional effects of this mask wearing. And so, but I can tell you this: I was in Idaho. I live in Idaho, and a lot of people were in Idaho. I saw more people from California, Colorado, and Washington I've seen in Idaho than forever. And I think they just don't want to wear a mask. They're like, they feel confined to wear a mask, and they want to come to a place where they can feel maybe a little bit more free to express themselves. And so, you know what? Idaho's open. So, and we're a very safe state. So come on over.
Oh,
So
I was just there last week. It was great.
Oh, were you really?
Yeah.
It's definitely a great state. And I think the economy in Idaho is actually booming. They've actually probably benefited from some of the other lockdowns from some of the other states, because a lot of people can't go anywhere else. So,
Right.
So let's talk about COVID-19. We're talking about masks. We're talking about COVID-19. And so tell me a little bit about COVID-19, and that people are talking about a vaccine. We have to basically stay locked down until we have a vaccine. What are your thoughts on herd immunity? Can you explain that to the viewers and to the listeners, and what your thoughts are on herd immunity, and compare that to an actual vaccine that could be produced?
Yeah, no, herd immunity is, that's always the best and ideal way to get to a point where, it's like your immune system is going to recognize a virus and immediately do what it needs to do, go through that complex system to fight off that virus and get rid of it. We know from experience, let's use the influenza vaccine as an example. There are some good years where maybe they're 60% accurate, and then there's some years where they may be as low as 33 to 35% accurate.
Wow.
Right? The problem with trying to rapidly develop this vaccine is, we're already seeing studies and evidence out there. I've got some articles here that have shown that it's already starting to mutate. It's
I've seen that. Yeah.
Yes, starting to weaken. And so they're creating a vaccine for what they suspected was the virus they were fighting after 3 months ago. And now it's already changed.
Yeah. Which is very typical, very, very typical of a virus, correct?
That is, virology 101.
Interesting.
Yeah.
So, I was reading the same thing, and I obviously I have a chemistry background. I've studied biochemistry, and I've studied biology as well. So I certainly don't have a virology background. However, I can read research papers. I absolutely can.
I can too.
Yeah. I mean, that's the thing, is like, just because I'm not an immunologist doesn't mean that, or you aren't either necessarily, doesn't mean that we can't read those things. And so, and so can the general public, by the way. Educate yourself. I absolutely encourage it. I didn't know this, and I was just reading this weekend. Maybe it was from some of the similar papers you were reading, is that they've seen different strains already of COVID-19, and they're weakening. And you say that that's very typical. Why? I did not know that. Why? And the researchers acted like that was typical. I didn't know that. Why is it typical that a virus starts out strong, but then weakens? Or what does weaken mean?
Well, weakens, so, to use that term again, mutate. So you've got just different facets of that virus that maybe are no longer there, or part of that virus molecular structure. And so the one study even talked about how the solar sun is playing a role in weakening it, and temperature is playing a role.
Interesting.
So, I think it was University of Pittsburgh is where maybe you were reading that, and I was trying to find that article where they found that it's probably mutated into 4, maybe the 5 different strains.
Something like that. I think it was Pitt, actually, University of Pittsburgh. You might be correct.
Right.
Yeah.
And that's good. I mean, that's what we wanted to do. We wanted to weaken. Now, I still think, based on the infectious fatality rate, that is dropping. I mean, that's the good thing about all the testing that's been done, right? Yeah. Is now we have a greater number, and then divide that by the fatalities, and that IFR, infectious fatality rate, just keeps dropping.
Yeah. Yeah. What is the latest IFR you've seen? The infection fatality rate. What's the latest one that you've seen?
Well, I saw, let's see, it's put out by the CDC, and it was just last week. And I want to say the current situation that we're in now, it's 0.0065, and it could go as low as 0.005.
That's interesting. Isn't that a less IFR than most flu seasons?
I looked that up, and I was trying to find a good source to really say, okay, this is a solid data. But I've seen the IFR for influenza at 0.04.
So it's higher. It's higher.
Right.
Wow. That's
And
interesting.
again,
I mean, you can't argue with the data. And it's like, whether you want to wear a mask or not, it's okay, but you can't have it both ways. Look at the data and show us how bad this disease is. What is the IFR? And so that's really, really interesting, Karl, to know those statistics.
I think the challenge, though, is folks will interchange the case fatality rate versus IFR. And so sometimes you get folks saying, oh, the case fatality rate is X number, it's really horrible. It's like, okay, yes, but let's make sure we differentiate between the two.
Well, let's do that. Explain that to the viewers. Yeah, go ahead. Describe I want to learn that too, because sometimes you just thrown out statistics and in the media, and we really don't know where they come from. So case fatality rate versus IFR. Explain that.
Case fatality rate is a known documented case. So that's why early on, we were getting horrible numbers. We were watching them throughout the world, right? And so confirmed cases divided by death, and boy, those numbers just kept coming back as very high and scary. I mean, that's why early on there was a lot of fear and panic. But now that they've been able to do both serum antibody testing, and they're getting more accurate testing with the nasal swab. Hopefully they are. I mean, you hear some of those reports out of Florida, and that's frustrating.
It is frustrating.
But so now suddenly that sheer number of those infected has gone up exponentially, right?
Right.
And then you take that fatality rate and divide it, and that's where you get that infectious fatality rate versus confirmed cases.
So what we were probably seeing early on is probably a potentially immunosuppressed or a sick individual, or maybe an elderly patient would die, and they were confirmed to die from COVID. That's why it looked like they had a very high death rate, which is probably true, but we didn't have enough testing numbers to say, hey, this doesn't infect everybody that's actually even somewhat healthy. Is that kind of what you would summarize that way?
Yeah, that's probably makes it even more clear than what I was trying to explain.
Yeah,
right.
No, that's very interesting. So very interesting. Again, you can't argue with that data. And so we have almost a 10x less time of death through infection from COVID-19. That's what the data is showing us so far, than we do versus the flu. So very, very interesting. Thank you very much, Karl, for that. And so speaking of testing, your clinic, and so you're in Wenatchee, Washington, correct?
Correct.
And so Karl is in central Washington. He's in the middle of Washington State. Okay. He's probably about 3 hours away from me in Idaho. And his was one of the first clinics in the state actually to sponsor and to do COVID-19 testing. So tell us a little bit about that. Tell us what you were doing with COVID-19 testing, what you were doing, and also some of the results, if you can share those with us, obviously with patient confidentiality at the top of the line. But tell us about that. What kind of a test was it? What were you showing? So on and so forth. Talk about that.
Yeah, no, it's that was one of those things where early April, I'm going, how come we're not doing more testing? How come the Department of Health in our state isn't getting out there and going, okay, we got to figure this out. When did this start? How long has this been going on? Instead, I think our Department of Health, I don't know what it is in Idaho, but it's been much more reactive from the very beginning.
I think most departments of health have been reactive, but go on. I want to hear your story.
So I found a company out of Seattle, US Biotech, that was doing serum antibody testing using both the IgM, which tells us, oh, you've had exposure within the last 7 to 10 days. You probably have a case of it. And then IgG, which is really the immune's memory cell, to say you were exposed to it sometime in the last 70 to 90, 120 days, and had to be a company or had to be an assay or a lab that had a high sensitivity specificity. So we wanted one that had at least 97% to 98%, giving us good, true, accurate values.
Yeah.
So that was standard, and compare that to the PCR nasal swab. So that's the one that everybody says, oh my goodness, they got to send this thing up into my brain, right? They don't really. It just further up into the nasal passage. But compare that to, so the sensitivity of that test is 70%. So that means you've got a good 30% or so that they're missing the true diagnosis. They could be having false positives.
Yeah.
So we started down this trail, and it was very fascinating what we discovered. Probably 3% were positive, which then if you again take that, if you find a positive, that probably with how infectious it was early on, that maybe 8 to 10 folks were also infected beyond that person in that community. But we did find the first case that I haven't published yet, but December 30th, 2020 in Kirkland, Washington. And
in
that
2019.
2019, yeah, 2019.
Interesting.
Yeah, it was actually a person that had gotten sick while they were in Kirkland with their family in Kirkland. And Kirkland, of course, was ground zero.
Right. Yep.
Right.
Yep.
And I think the first case documented is New England Journal of Medicine, January 20th in Snohomish.
But Kirkland was basically, it was rampant through an elderly care facility, correct?
It was, right. Yeah. But it was just so fascinating to find this case, because then this person was able to date it back to December 18th, and then happened to be the son-in-law. The son-in-law said, oh, I got sick probably back in December 12th, and I just continued working. I'm a salesperson. I'm in and out of hospitals and facilities all in that area.
Interesting. Very. This is one thing that I've always wondered about. Why is it that it looks like you can, for example, you can have a household of 5 people, and obviously there's many variables here. Is it a poor test or immune systems or what? And one of them will test positive. They've obviously all been in close contact with one another, but not everybody in that group of 5 will test positive. Why? Right. Why? Certainly they've been exposed, right? Is it just that their IgG or their immune system is not activated enough to even say they had it? Explain that, Karl.
Yeah, so I think that's definitely part of it. There's already a substandard or some of the population, about 8%, that will not seroconvert. So you have that segment.
Oh, and what is, explain that to the listeners. What does that mean? They will not seroconvert.
Okay, so yeah, so they get the virus, and then we do the serum antibody test, so blood draw, and then we're looking for that, particularly that IgG, that memory cell that says, hey, we had it. Well, there's some good data out there that 8% of those just won't show up.
Even though they've been exposed to it.
Even though they've been exposed to it, yeah. Right.
Very, very interesting.
There's another substandard of the population that has genetic issues with even the immune system showing up. And so then it should cause us as scientists, researchers, to go, what's going on with their T cells?
Sure. Yeah. Yes. Yeah. Now, why tell the viewers, non-scientists especially, why would that cause us to raise an eyebrow and say, hey, what's going on with their T cells?
Because it all starts with the immune system, which is, again, this beautiful, complex system within our body. That's why we're able to fight off so many thousands and thousands and thousands of infection, right? And so the T cells are part of that whole memory system that recognizes, hey, I saw this virus 20 years ago, and we're here to take care of it. Now, I don't know if T cell has that many years of memory in it, but I'm just using that as an example. But here's something that I discovered that I think it was back on July 2nd. I was reading through some of the Washington State data, and in our state, this is on hospitalizations. Over 50% of hospitalizations were from the Ukrainian community, and then the second highest was some community from outside the Philippines, and then the third highest, about 35%, were the Russian community. So I started asking, okay, what is the difference between why are the Ukrainian and Russian communities the highest percentage of hospitalizations in the whole state of Washington? And to me, it was like, well, that should be a no-brainer for the Department of Health to start going, okay, what can we do to figure out how to protect these communities and what's going on within these communities? So I asked a friend of mine who's part of that Slavic community, and she said, "Oh, we congregate in big groups. We love to hug. We love to sing." I said, "Okay, but that doesn't explain why the Latino community, which also congregates together, which also is gregarious in their affection, and they also love to, sing. Why is their hospitalization usage in the state of Washington less than 10%, lower than all cases?"
That's interesting. That's
Yeah.
So you think there might be a genetic component there?
Oh, it got me. It was one of those things that was getting me all excited, going, "Oh my goodness, I would love to look at their IL-6 or IL-5. These are immune
Yes.
systems,
Yeah, absolutely. Yeah.
and their T cells." So here I'm getting all excited, but it's like there's nothing I can really do about it.
Well, it is cool. And I thought about that too, as I see cases and they have these maps on where there's a lot of cases and where there's not. And a lot of times you can break it down via demographics, right?
Right.
About where large communities congregate. And so but I've also thought of this, Karl, just speaking scientist to scientist here. It's like, yes, we should look into, is there a genetic component? It also could be environmental based upon their habits. Like, how do they use hospitals? There's a lot of communities that may be gregarious, may be close, they may gather in big groups, but they just don't go to hospitals. They don't go for whatever reason. They might not, either they might not get sick, or they don't want to know, or they don't go access the hospital. So some of that, don't you think, could also be attributed to possibly how they use the hospitals and possibly over usage of those hospitals?
Oh yeah, no, certainly. And I think if you look at John Ioannidis, Dr. Ioannidis out of Stanford, he talks about how one of the worst things that happened with this pandemic, and again, part of this is, I think, contributed to the media just getting that panic and that hysteria out. One of the worst places to be at was a hospital, right?
Right.
So you suddenly are panicking all these folks to congregate in hospital systems. And what happens when you have all this nosocomial or hospital or viral loading all in one congregated place?
Yeah.
It just makes the infection worse.
Way worse. Very, very interesting. So we've kind of developed and really talked about some really good topics on even vaccine, and we talked a little bit about herd immunity. I want to get to that in a minute too, but some things about testing and certain populations, confirmation bias. We even talk about the infection rate versus the case death rate, which all those are important. So I want to really now get your thoughts on, you talked about a vaccine, and we know that you're saying some years an influenza vaccine, because of different strains, is 30% effective at best. Okay. And we certainly know, I think any right-minded individual would know, or scientists would say, we're not going to get even to 90% effective with a vaccine, just with the data we know historically with a virus, probably. Okay. So why is herd immunity in this situation possibly better than a vaccine? Explain that.
Well, it still goes back to, again, so we want the herd, which is mostly in this case the younger population that we know from the 3 to 4 or 5 months of data now that they can actually tolerate this very well.
Very well. Yes.
Yeah. The infectious fatality rate within this group is extremely low. I mean, it's barely measurable, truly.
Yeah.
And then when you get 19 or 18 and under, it is like a blip.
It's almost zero. I mean, from the
Right.
numbers I've looked at, it's almost zero. I think the numbers I saw were some of the numbers as far as, correlating this to age were anybody. I think there are 30, and I know any death is tragic, by the way. There are 30 deaths of anybody in the nation, or maybe this is world. I'm not sure. I'm not sure about that one.
I think it might be the world because it's so small. Right.
Yeah, it's 30 deaths total of anybody under 18. And you've got to think that certainly to look into those histories, there was probably some immunocompromised people. Maybe they had cystic fibrosis or who knows what they had, but it's very, very small. So young people, yeah, they're not attributable to this. And I think, these statistics very well, obviously, Karl. I think the average age of death from COVID in the United States is age 78.
Yes, and so that's really where it comes back to. We need to protect that vulnerable population.
Yes, and I agree. And also, isn't that the average death of a human being in the United States anyway? Is about 76, 77, 78?
Yeah, I think it's about 78 for men, about 82 for females.
Okay, so they could have died from influenza or pneumonia or something else, congestive heart failure, but these ones particularly died from COVID-19. So,
right.
So herd immunity, we're especially for young people. Again, we're on this topic. It's a big one because it's hard to understand. I don't think we actually understand herd immunity really on a large genetic even basis. So describe it and how close are we to getting that and why it's better than a vaccine. Keep going.
Because again, your natural immunity is just going to be so much stronger and robust than a synthetic man-made vaccine, that they're doing their best job of estimating, how this vaccine can fight that virus, right?
In other words, they're predicting on what this virus is going to look like when it mutates.
Correct. Yes. Now, okay. I don't remember which podcast I was listening to, but it was just last week where they said how ironic that a place in Queens, New York called Corona has some of the highest immunity because it just went rampant through that community.
Interesting.
And it was just kind of like, okay, how did that come out? Where Corona, New York, in this
that is very interesting, actually. Do they have a really young population there or something? Do you know in that particular area?
Yeah, I don't know. It was just kind of like a mention in this podcast I was listening to, and go, I need to really look into this, but I haven't gone back to it.
Yeah, very, very ironic that it's called that area as well. And so, how close are we? Well, what is considered herd immunity? What percentage of the people have to be exposed to get to herd immunity? I've seen some different numbers there. What are your thoughts on that?
Yeah, I've seen the numbers 60 to 70%, but generally kind of at 60%. So even in this area, I saw a report that people were getting excited or actually not excited. It was more of a report that, oh my goodness, look at all these 20 to 29-year-olds that are testing positive. We need to do something to, curtail this. And it's like, no, this is
you want that.
Yeah. This is the population we wanted to have it 2 or 3 or 4 months ago.
Right.
And we just delayed them getting it because of these shutdowns.
Yeah, absolutely.
So no, by all means, get them out there, get this, herd immunity or this T cell, memory cell functioning well. And that way, we can just continue on with life.
Yeah. Obviously be healthy on your own, eat right, move, have good relationships, get good, sleep well, get adequate rest. Absolutely. Those 4 things. And you're going to have a very, very strong immune system and very few metabolic disorders. And so that's great. So where are we at now? So you're saying about 60% of people being exposed to it. What are the numbers that we're seeing now for exposure? Do you know those numbers?
Those are numbers I don't know. That's that one's been hard to grasp, and it's just hard to know that data.
Yeah,
I mean,
it definitely is. I mean,
yeah, that's where I would argue, okay, really did the shutdowns work? Because here we are going through an uptick, which we expected,
yeah,
and we shouldn't be running from it. We should be, okay, embracing it, and again, protecting the lives that will be impacted by this.
right. And so, and it looks like a country like, wasn't Sweden one of the countries that did that, or a few of the Norwegian countries that they just protected their elderly population? They never had a shutdown, and they actually came out with some really good outcomes. Is that the correct country, or do you know of that one?
Yeah, no, Sweden, and it was definitely interesting watching kind of the social media and how, oh, look, Sweden's doing bad, and then you'd have the folks come on and go, see, that didn't work, but then suddenly the numbers started to change again, and sure enough, Sweden still kind of comes out as doing quite well
Yeah.
overall.
Yeah. With no
Yep.
quarantine to the whole nation or all populations. Very, and no shutdowns that I understand to their economy. So
Right.
that's really, really good. And so, well, we're getting there. I think the number I saw was 20%, 20 to 30% of people that have been exposed so far in the United States. I mean, the bottom line is we're all going to be exposed to this. We just probably are going to be exposed to this. And
Right.
so you have to kind of embrace that and just be as healthy as possible and be ready for when you do get sick. And I don't wish it upon anybody to get the actual symptoms, but it appears that a lot of people are asymptomatic or not having symptoms or very few symptoms at all, especially in the younger populations. They don't really even know they had it. And so that's the best case scenario. So I'm hoping we're getting there. But in summary, herd immunity, we're looking at, people getting exposed, especially the younger, more healthy populations. That's going to be your best asset for beating this particular virus or any virus at that point. And that is, your body knows better on how to fight these things than anything else that it can be. And so, as good as a vaccine can be, it can never be as responsive as your body can be, because it's like we can only make a vaccine as good as we know what the virus looks like, and it's changing constantly, just like the flu. So that's excellent. What great data! What a great conversation there, Karl. I really, really appreciate your time on all of that. Tell me about direct primary care. I'm not only excited about this, I do direct primary care. Obviously, I've worked with you on that, and I appreciate all your time on that. Tell us about direct primary care. I think it might be even another podcast for another day, but tell us, what is direct primary care that you do with your patients in your clinic, and why it is a better option than the most primary care models that most people have nowadays. Tell us about that.
Direct primary care. So that was, one of those evolutionary aha moments for me back in 2015, as I kind of been venturing along this pathway of breaking out of the system, and then stumbled across.
What do you mean by the system? Tell people what you mean by the system. So what I hint that you're saying there is that there was something about the system that you didn't like. And I agree with you, by the way. And I don't think it's better for patients, the current system. So how did you break away? Tell us about the system and what you did to break away.
Yeah, so I kind of refer to the system as the sickness model system. And again, going back to, seeing 25 to 30 patients in any given day and just going home exhausted, but never really feeling like you're making a difference. And so that's where I refer to, okay, that's the sickness model. What I like about the direct primary care model is I call it the wellness model, the prevention model. Oh, I get to spend a good 30, 45 minutes, an hour with my patient, learning about them. And then with the direct primary care model, it's a membership based. And so folks are paying X number of dollars per month, and it ranges anywhere across the country. On average, it's probably about, I would say $70 per month on average, which compare that to what you're paying for insurance. Yeah.
Not even close.
It's not even close, right? And so I get to spend more time with my patients. I get to find out, okay, really, what is the root cause and the root issue of what's going on. I get to have the joy of working so closely with my patients that I can reverse their diabetes by just, focusing on their diet, their exercise, and then pulling them off their medications, as opposed to me writing yet another prescription
Yeah.
for a medication.
So
That's huge.
it's huge, and that is absolutely. So you're actually treating the cause instead of just symptoms, and I really applaud you for that. And Karl, those are difficult conversations to have even with a patient sometimes, to say, hey, you're overweight, you have to change your diet, and you got to start moving a little bit. And I really applaud you for having that courage, because a lot of even doctors in our system don't. They just think it's the easy way out to maybe give them a prescription, where they're defeating the purpose of trying to actually cure the patient. So I want to get to this though, because when I tell people that I use direct primary care services like I have with you, is that tell us why it's different. Tell us about what your access looks like. Because see, currently, you have to make an appointment with your doctor, and that might be 2 months away. And then you get an appointment for 15 minutes and they don't talk to you much. Access is a big deal to me, and convenience. And that's really what I like about you. For example, you're accessible. You're accessible via app, via email, via text, whatever it is. Talk about that access and why that's important.
Yeah, no, that's a great example. I mean, so the access, we did not miss a beat during this shutdown, and
Awesome.
we got shut down starting March 17th, and I think we're still only in phase 1.5, and you guys are in 4, right?
Yeah, something like that. I can't keep track of it either, but we don't. I think we only have limitations on very large gatherings now, or something like that.
Uh,
Yeah.
Okay, so we never missed a beat because we were already set up to go televideo, texting, the app support where folks have access to us, and so it was we just continued on.
That's
It's like,
awesome.
oh well, and in fact, I had this year I made a proposal to a company of 400. I said, give me your 15 diabetics, some of your most challenging employees, and at the end of this year, then you guys look at bringing the rest of your employees onto this wellness model. And so we didn't even miss a beat with some of these diabetic patients. One gentleman that finally, when he did get to come in for his face-to-face, he was so excited because we'd gotten his Lantus down from 150 units to 35 units. We'd gotten rid of his daily insulin that he was taking. He was so excited that he even went and told his endocrinologist.
Oh my. So he'd been with an endocrinologist that couldn't. Okay.
Right.
Didn't do what you did. I'll just say didn't do what you did. And you know what, Karl, I applaud you for that. I applaud you for many reasons on that. First of all, because you improved the health of a patient. So you got them off of the majority of their insulin. Are they a type 2 diabetic?
They're type 2 diabetic, right?
Okay. So it's possible you may get them off of all of their insulin if their pancreas is still working functionally at this point.
Right.
That's possible.
Yeah.
Good for you. Congratulations. I also like to hear your story where you took the entrepreneurial mindset and you approached a company with a proposal to say, hey, I want to help your patients get better. And here's how I'm going to do it. You guys give me the worst case scenarios, or the people that may not be the healthiest in your companies. I want to show you that I can get a return on investment or get them to be more healthy. And then, hey, let's talk about what next year looks like with your whole organization. Good for you. And
Yeah.
I think that a lot of our medical community has forgot about the entrepreneurial mindset of medicine and entrepreneurial mindset of everything. Because when you have an economic stake in it, you want better outcomes for your patients. And
Oh,
yeah, exactly. But we're told in the media exactly the opposite. And that's just not true. And you are a perfect example, Karl. So thank you for being courageous and stepping out of that box in that system, which is scary to do. and going out on your own and creating or starting, or like others in the industry, starting your own direct primary care model where you are face to face and you have good one-on-one interactions with your patients. Really, really good job. So congratulations on that.
Yeah, you're welcome, and thank you.
And I absolutely think, what I liked about this is I didn't miss any healthcare during the quarantine either. I don't use a lot of healthcare services. You and I talked during the quarantine, which was awesome. Didn't miss a beat. We just scheduled it, and not a big deal. We did a Skype or a call or something,
Right.
a video call. And I just saw thinking, wow, this is really a wake-up call for people that this is 2020. Do we really need all these hospital buildings and all these big buildings that we put people in to come in to do patient care? No.
Right.
I mean, we just don't. And those are facts that a lot of people don't want to hear about because it maybe takes away of some of their apparent power. But what you are doing is incredible, and you're changing people's lives. So kudos to you and congratulations, and thank you very much. So,
Yes.
So we're getting ready to wind it down, and I always like to ask a couple of questions. And so one of the questions I want to ask you about, what are you passionate about? I can see you're passionate about health, you're passionate about statistics, your immunology, your science. That's really, really cool. What are you passionate about? What gets you out of bed in the morning?
No, I mean those things definitely get me out of bed, but probably the one of the greatest. Well, I have my family is my passion too. That's in terms of my children, but the one passion that has been taken away from me is I love traveling and I love eating good food from different parts of the world. And so, COVID-19 world, I'll use the term, sucks.
Yeah, I get that. I'm used to traveling as well and eating all around the world and enjoying different demographics of food and so on and so forth. And yeah,
Right.
so you like traveling. That's a passion of yours, huh? Where's the coolest place you've been?
Where's the coolest place I've been?
Yeah.
Oh my goodness. I love being in Thailand. I've been in Costa Rica. I've been in China. I didn't care for that so much. I'll probably Kathmandu, visiting friends that have been living there, and so
Wow.
they had been there 20 years. So being in a community that at least that family could take us around and have us see things that tourists don't see. That was probably the most impactful.
That is so cool. And so what was the food experience like there in Kathmandu?
It was tasty. It was good. It was, of course, doing any traveling like that too, you have to kind of be careful about what you eat, and or you'll be spending a lot of time on the throne. So
right.
But no, it was good food. It was spectacular views. Oh my goodness, the mountains there. Yeah.
Only imagine. Oh,
beautiful country. It's just unfortunate because there's so much, it's a kingship there. It's corrupt.
interesting. Yeah, I've heard those stories. That's really, really unfortunate. That's unfortunate. But what a great pleasure and experience that you got to visit there. That's really, really awesome. That's great. Yeah. So I like to end it up with, obviously you have this never be outworked mindset. You're always going, you're always looking for additional business, looking to, help your patients out. And that's our theme on the Secrets of Success podcast show. And so a lot of that has to do with doing things that are difficult and uncomfortable, and risk taking. And it causes us to have what a lot of people may look at, or sometimes we even reflect on internally and we look at as a failure. But then we move on, we get up, because I don't think there's really any failures. They're just learning experiences. We get up, we move on, and then we say, hey, I learned from that and I'm better off because of it. So what would you tell the audience that's maybe one of your apparent failures that actually, when you stopped and looked back on it, caused you more success in the end?
Yeah, I would say probably the biggest thing was when a high school counselor sat me down and said, you know what, you're not going to be college education graduate. You might as well go find a factory job. They looked at my GPA, which was lousy.
Interesting.
And I just turned around and didn't say anything and said, nope, that's not going to be me. But it was interesting that this counselor was saying, yeah, you've basically, you didn't do so well in high school. You failed, right?
Interesting.
So
Yeah.
go get a job at some factory and good luck.
What caused, did it cause you to change your mindset, or is it that maybe like myself, I just necessarily am not a good test taker necessarily. And so what did that, you just always wanted to be in the sciences or be in healthcare, or what caused you to change this and not listen to his advice?
Oh, probably my discipline of all those years. I've been a cross country runner, and when you do cross country running, you might be starting out in the middle of the pack, and then you just keep running, and bit by bit, you're
That's
taking
right.
off your competitors,
Yeah.
and I was always, or not always, but I was often in the top five during my high school years of running, and so I just kind of
Awesome.
went into my cross country mode.
That's awesome. Yeah. And you just keep going one step at a time. Yeah.
Right.
I used to run as a wrestler, never competitively, certainly, but you think about that and it's just, like if you want to run 3 miles or whatever, that can be sometimes a daunting task, but it's just one step at a time and you keep going. That's just like life. And that is a great mindset to have. Really,
Well,
really, really
yeah,
good.
can you hear me?
Yeah. Yeah.
So here's a story of a hero of mine. So my cross country coach, really impacted me in so many ways. And when I went back to visit him at the high school, he'd already been at this high school for 50 plus years. I graduated in 1981
Okay.
and went there in 2012. And Coach Bailey said, "Oh, Karl, good to see you," and just almost could name every one of my friends.
Wow.
And I just thought, what an impact he made on me, and just the fact that, this many years later, he could name my friends and just name the character of who my friends were.
That's awesome. I've heard a lot of stories like that. I was a wrestling coach myself, and just thinking about the impact not only the kids had on me, but that some of the parents said that I had on them. And I think about my own coaches in high school. Oh my goodness. It was like whatever they said, you just listened.
Right.
That's awesome that you had that story. It's a great story, Karl. It's very, very inspiring, and kudos to your coach, and kudos to you for listening too, because that is inspiring. And so,
Mhm.
Karl, this has been a great show. We're wrapping it up here. This has been wonderful. You've been a fantastic guest. I've learned so much about COVID-19, herd immunity, masks, direct primary care, vaccines, your story. It's just been amazing. Thank you very much. And you too can go look up my website, drsneedham.com. We're already friends on Facebook, but I'm also on Instagram. I'm on LinkedIn, and you and I are connected on LinkedIn. You can certainly follow me on YouTube or listen to this podcast. We'll have it up in about a week or so on Spotify, iTunes, SoundCloud as well, and on YouTube. And
Okay.
thank you very, very much for your time. We're going to have some really cool shows coming up where we're going to be talking about bodybuilding. We're going to be talking about eating disorders. We're going to be talking about relationships. We're going to get really, really nutrition. We're going to get really, really vulnerable over the next couple of weeks and the next couple of months. And it's going to be really, really cool. Oh, by the way, we're going to be having I think one of the best wrestling teams in the nation there, and their coaches on the line, and talk about how many kids they've inspired. We're going to have them in a couple of weeks as well. And we're going to have some great shows. And Karl, you've been a part of that. And so thank you very much. And I'm sure we'll be connecting and talking soon. Thanks again. And you have a great day. Thanks for taking time with us today, Karl.
Okay. Thank you.